Hey, GLP-1 plus size community. Before we jump into the podcast, please take the time to leave us a 5-star review on whatever audio platform you're listening to the podcast on. Share your story and how the podcast has helped you. This will help us get referred up in the audio platform so that we can reach more people that need our help. Our support and guidance from our doctors. Help us get loud and change things. Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on the Plus Sides Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus Sides Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together, because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault.
"20 seconds a week to lose 20% of your weight in a year with diet and exercise." That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Welcome to the Plus Size
Hey.
Podcast. Hey, Kat.
Hi.
How you doing?
Had a little mouthful of protein pudding.
I see. I'm glad you're getting it in.
Yeah, you gotta get your protein in. It was a busy day.
Yep. Well, we have lots of good stuff coming up today, but we are going to have a heavy conversation about a lot about PCOS, insulin resistance, and I think that's just like one of the biggest questions that we get that people want to understand more, because it's very complicated and often misdiagnosed and or not diagnosed at all. So we're going to talk a lot about that with our special doctor friend. But if you are new to the Plus Size Podcast, I am Kim, and we are an advocacy and education podcast around the disease of obesity, type 2 diabetes, insulin resistance, PCOS. We even talk about thyroid issues and kind of any of the things that could impede your health, really as it pertains to, I don't know, weight, excess adipose tissue.
Right.
Sure.
You know, after like all the doctors that we talked to, it's still like such a work in progress.
It
right?
really is. I mean, we're still learning so much, but when we started this, it was definitely, we wanted to give a voice to a marginalized community. So if you're new about that, that's what we really like to do. We usually have on community guests. Our community guests cannot make it tonight, but we often will have someone come on and share their story, because we think it's important for you to hear different perspectives and for you to know that you're not alone, for you to know that it's not your fault, for you to know that it is a disease and there are treatments for it and you are worthy of care. And we want you to have all of the information that you need to be able to advocate for your health, to be able to get the care that you deserve. So that's why we bring on our doctors, to be able to validate those stories with facts, science, and data. So today you're just going to kind of get Kat and I talking a little bit about it, since our guest couldn't make it, but that's okay. That's okay. It happens. People have lives. And Kat is my very good friend and does the podcast with me. So hey, Kat, why don't you tell people a little bit about you?
We're IRLs.
We are IRLs, in real life friends, like 15 years.
It's been a while. Yeah.
And you found me like all advocating on TikTok, and you were like,
wait a minute. I'm on it too. But I've been so secretive about it. Like the funny thing is, so when I'm Kat. Protein pudding got stuck in my throat. And I've lost, like, it depends on the day of the week, 55 to 60 pounds. on using Mounjaro or tirzepatide. Now I'm on compound tirzepatide because we're going through a little static with my insurance and they want to take my candy away. It's fine. But yeah, I used to remember when I was staying at my bestie's house for 1 month in between selling her house and moving into this one. And I remember I got a shipment of Mounjaro to her door and I was like, "Oh, it's something for my cooking. It's just something for my baking."
Oh my gosh.
Yeah.
See,
Now
but
the,
that's
the, the
because
cat's out the bag.
yeah, the cat's out the bag.
Way out of the bag now.
It's way out. They all know now. You're in our podcast was number 18 a couple of weeks ago. Yeah.
So
Yeah, that was a big deal.
no more secrets. She's on it now too.
I love it.
Yeah.
Well, it's all out. Cat's out of the bag. Real time.
Real time.
So let's invite in our doctor guest. What do you think? What do you say?
Yeah.
Okay.
Dr. J. I just love the name. So.
Hey, Dr. J.
Hi, guys.
We're so glad to have you.
Thank you so much. I'm really excited to be here, and congratulations on being number 18. That's huge.
Thank you. Yeah, we were like, we just this little scrappy podcast. Yeah. So, it goes up and down every week, but like I remember when we hit the 100 and we were like, wow. And then then those like always they were like number 18. And we're like, said who? So it's great though. Like, I mean, because more people can learn and that's what we want. That's what we want, So we're so glad to have you. I actually this is how I found out about you. I was looking at some educational material for the Obesity Coalition and you had done a talk and you were talking a lot about PCOS. And I was like, we need her. And you were so kind to come on and contribute to this movement and helping people. So if you could tell us a little bit about who you are so everybody else knows and how you help people, we would appreciate that.
Absolutely. So first of all, thank you guys for inviting me here. I'm really excited to share some information with our listeners and our viewers. So I'm Priya Jaisinghani. I'm a triple board certified physician. I'm certified in internal medicine, endocrinology, and obesity medicine. And I'm currently a clinical assistant professor at NYU. I really came into this field because I saw a lot of minority communities really ravaged with chronic diseases like type 2 diabetes, obesity, and I really wanted to treat the intersection of those fields. So really focus on a lot of metabolic conditions, and that's what I'm doing on a daily basis.
Awesome. I love it. Clearly. So a little bit about like Kat and I, just so you know, because we're going to be the community guest tonight. So we both have struggled with obesity since we were young, very young. Always been tall, big, fairly athletic. Kat, very athletic. Me, just like regular athletic. I don't know. And I don't know if like just regular. Like I was never super good at anything, but I did all the things, And but very active. But we've always struggled. Kat and I both do struggle with binge eating disorder. I have not had any issues with binge eating disorder in 2 years since I started these medications. So, and I know it helps Kat quite a bit too.
Yeah.
So we talk about that because we think it's important because sometimes I think we realize on the show that there's a lot like with there's many things that contribute, just like with obesity, right? But this being an amazing tool to help with that and also help with the biological dysfunction, I think it's been pretty life-changing for us to where, I mean, for me, like having food noise be quieted and all those different things, it was just sort of like, once I realized I just needed everyone to know. Like, I was just like, I just have to tell everybody. It's like, so we tease sometimes like we're GLP-1 evangelists. Hallelujah.
It's okay.
Because we're like creators that talk about it all the time. So, but in terms of this, there may be people that are just joining because this happens all the time. People that are just joining, if they don't know what endocrinology is, right? Because a lot of people think that it's just diabetes doctors. That's a very common, I think, misconception. Can you tell us a little bit about how endocrinology treats like metabolic conditions or like what that commonality is?
Yeah, absolutely. So the endocrine system, right? It's actually a vast network of glands that secrete hormones. And these hormones are in charge of, they're almost like the master controllers of a variety of functions. And that can range from your metabolism to hunger cues to measurements like your sodium, potassium, your blood pressure, all the way to your bone health, your reproductive health. So it has many, many vast effects on your body and your entire system and many phases of your life. So, we really look at as endocrinologists, excess hormone, deficiencies in hormone, and then just the right levels of hormones. And when we have imbalances, right, for example, with your metabolism, that can lead to metabolic diseases or syndromes, right? So that's part of what we treat as endocrinologists. And you're right, a lot of us, a lot of people think we're just diabetes doctors, but we treat adrenal conditions, which are small glands on top of the kidney. We treat pituitary and hypothalamic conditions, which are, in your brain. And then we treat thyroid conditions, we treat diabetes, we treat PCOS, we treat insulin resistance, we treat many, many things. So there is a very strong intersection between metabolism and the endocrine system. And there's also a lot of hormones that are secreted from almost larger systems of glands, right? What we call the enteroendocrine system, or your gut. And, that's also responsible for a lot of hormone secretion that relates to hunger and hunger cues.
Wow.
Fascinating.
That's like the best thing I've ever heard anybody say in like a little bit. That was short. Right there, ladies and gentlemen.
Definitely.
Right there.
All right. So I nerded out a little bit on your OAC, the Obesity Action Coalition lecture.
We are
It's
such
pudding. I still got that protein pudding.
Adam and I are in like marketing and support and operations, and we're like, doctors talking about endocrinology.
So you went over the criteria of PCOS, right? You mentioned the Rotterdam criteria. This might be a little bit too visceral, but I wanted to know, what is that specifically, Rotterdam criteria? And then what is the criteria used to diagnose PCOS?
Yeah. So let's start with what is PCOS, right? So polycystic ovarian syndrome, right? So we actually don't know a lot about the pathophysiology or what causes it, how things stem and kind of progress in the body. And the Rotterdam criteria is one of the criteria that we use to commonly diagnose PCOS. It's probably one of the most widely used. And really, it focuses on 3 components of what can make up PCOS, and you need 2 out of 3 to qualify for a diagnosis of PCOS. So we can kind of walk through each one. So the first one is menstrual irregularities, right? And this definition can actually differ on the point of time you are in your life. So for example, if you're a female who is 3 years after menstruation up to perimenopause, then, your definition of an irregular period can be menstrual cycle less than 21 days apart, or greater than 35 days apart, or less than 8 times a year. So really important to note if you're having irregularities in your menstrual cycles, and to let a doctor know, because that's one of the criteria. The second criteria is really relating to what we call hyperandrogenism, right? So higher levels of male hormone, either what we call biochemically or clinically, right? So biochemically, we would do some testing on your hormone levels to see if you have elevated levels of, for example, testosterone. Or we would ask you about signs and symptoms of that, right? So signs and symptoms of excessive male hormone can be, for example, excessive hair growth, or what we call hirsutism in a male pattern distribution. So maybe on the back, chest, lower abdomen, acne, right? And for some people, even hair loss, right? So that's the second criteria. Third criteria is actually dependent on your ovaries, right? And really, you need imaging for that. So oftentimes people will go and get, imaging for that, to look at the follicle numbers per ovary, the ovarian volume. So this is, really done through imaging. And follicles are these small, really fluid-filled sacs in the ovary that contain and they release eggs, right? So they actually also produce a hormone called AMH. And that's another thing that we can check in lieu of this imaging, right? So that was actually a new criteria that was added. So you need 2 out of 3. You need either irregular menstrual cycles, clinical signs of elevated male hormone, or biochemical signs, so meaning on blood work, or, the specific distribution or change in volume of the follicle number or ovarian volume that's maybe seen on imaging, or a difference in your AMH level, or this anti-Müllerian hormone level that can be checked. So generally 2 out of 3. So that also goes to say that you can have regular menstrual cycles and still have PCOS, right? So sometimes that can be really confusing for people, because they're like, well, I don't really have irregularities in my menstrual cycle, but I do have these other signs and symptoms. Or they might say, I do have, irregularities in my menstrual cycle, but I don't really know who to talk to about this.
That's so interesting. I got a question to build on that.
Yeah.
Mine, I've just, what? I used to be so like, I don't want to talk about my periods, whatever. We're gonna let it loose. Mine have been irregular ever since I got them, since I was 12. I would get them twice in a month sometimes, and I would go 2 months and get one, but they've always been irregular. And then I started to bleed in between as well. And that was due to polyps, we think, because it started to come back a little bit. But I wonder if, my doctor did the opposite. I took a blood test and it was negative for PCOS, but I wonder, with irregular periods being that irregular, is there anything else that it could be an indication of, and as well as like bleeding in between as well?
Yeah. So that's why it's really important. As endocrinologists, we co-manage PCOS sometimes with gynecologists, because there are things that can cause, differences in your menstrual cycles, whether that's, the amount intensity of bleeding that you have, the timing, symptoms like cramping, right? So we tell people to get screened for even things like fibroids, right? Which could maybe cause heavier bleeding.
Right. Interesting.
Yeah, I think I think that I never knew what to ask. Like, for me, like, my cycle would be short. Mine were short. And I also have a lot of pain when I ovulate. Like, I have to take Motrin and stuff, like, because it really hurts. And I had infertility issues, so I had like 2 miscarriages. And they kind of, but I always had obesity this whole time. And I was very much dismissed. I was just like, you should just lose weight. You should just lose weight. If you lose weight, it'll all work out. Just go lose weight, you know? And I'm kind of in this echo chamber, like on socials and on TikTok, with the things that we talk about and hanging out with the doctors and all things. And I found that, like, I kind of thought that, I guess I was thinking things were changing way more than they actually are. Because when I went to do my yearly recently, my OB was like, so you're taking Mounjaro, like, why are you taking it? And I was like, well, I have obesity. I'm taking it for obesity, and that's what my insurance will pay for it. You have to do a PA and all the things, and then he launched into that I should lose more weight and that I was not small enough. And he didn't ask me how. He was just like, and then he started telling me that I should be the same, like closer to what his wife's weight was, which was like 120, 120. I'm not kidding. 120, 125. And because women have a smaller frame. And I said, I'm actually very tall and genetically just a larger human. Like, if you look at my genes and all the other humans in my family, and he was like, it doesn't matter. You should never, ever weigh more than 200 pounds, ever. You should never, ever. There should never be anything. I was like, and I am on the table in my
scrub
with this thing over my tank, and this man is lecturing me and telling me what I need to do. And then he was like, are you doing anything else? And I went, I do all the things. Like, I don't want to be like, actually, I have a health and wellness podcast and everything, but like, I don't want to get into it because I'm just there for him to check my parts. You know what I'm saying? But like, it just blew my mind that the audacity and the ignorance, like, none of that is actually true. We know that there are certain bodies, like, that are not going to be under 200 pounds, and that's not a bad thing, and that there are so many different things. But it was so, and he's young. Like, I was like, how, and I was furious, and I made a TikTok after, and I was so hurt, and all I kept thinking was, this is why people end up with diabetes that have obesity, because they get this kind of treatment, right? And they get this kind of, I would say, like, I don't want to say ignorance, but I kind of do, because like ignorance just means not informed, right? Where he doesn't know, and he doesn't know how to talk to a woman, which is crazy because he looks at vaginas all day. So I don't understand, but it's true. It's my podcast. I can say what I want, but it's true. But he clearly didn't. And I am a very loud, obnoxious advocate. And I was immediately back to where I was 2 years ago, just taking it in and feeling like crap. You know what I'm saying? Because I didn't know to question my doctors. I didn't know how to say, help me understand this, right? I just sort of took it. And I have a lot of regrets because I wish that I had known about Victoza, right? After I had my son, because when all my weight came back and then I really couldn't get it off, I wish I had known. Maybe I could have had more children. I love being a mother. It's my favorite thing. And for whatever reason, like, didn't get, I mean, I think this is sort of my baby now, so that's okay. But I wanted more children, but I didn't know. And I just want anybody in our listening audience, like, please take an opportunity to listen to this. If you are planning for a family, to know what questions to ask. And we're going to talk about all those things now that I'm off my soapbox. Sorry about that.
No, Kim, this is really important. First of all, I'm sorry you went through that. But what I will say as a female in medicine, a woman of color in medicine, we are not heard always, right? And just as a woman, being a doctor, being of color, but just as a woman, and I would say even being a patient in the past, or even now, right? So I would say that we have to be advocates for ourselves. We need to find a physician that is actually going to hear you, see you, listen to you, right? And believe what you're going through. Because you're right, oftentimes we are dismissed. And there's a second layer on top of that, which you mentioned, which is weight stigma and bias, right? Yes. So that is pervasive in the community, but also don't forget it's pervasive in the medical community. And we're trying our best, to educate not only the community, but doctors on how to approach weight, how to speak respectfully about weight, how to open that discussion for when people are ready, and also not to blame individuals. Yes. This is a disease that is not someone's fault. It's a disease, right? You need to understand that it's a chronic disease. It's relapsing, right? It can come and go is what it means. And it's progressive, right? And it's related to so many other disease processes, right? And I think the main thing is not to hold people at fault. I have countless patients that have come in and told me, that my cancer was blamed on my weight, sorry, not my cancer was blamed. What they were trying to say is that their problem, whatever their situation or their symptom was blamed on their weight. And then it was found out that they had cancer, right? Or that, their weight was used as a reason, just lose weight, you'll be fine, and then it was found that they had some other aggressive process going on. That we need to be very mindful of. We need to listen to a person's symptoms. Sure, weight, obesity as a disease is linked to 200 other diseases, right? And we understand the risks of that, but we also want to make sure that it's not just used as a scapegoat to blanket other symptoms or signs that someone may be having of some other process. So it's really important not to blame or to not do the due justice and workup that somebody deserves.
Yeah, absolutely. I mean, I think I think there has to be, I got a lot of heat recently from lots of people. But specifically when I posted that one of the doctors been on our show, Dr. Glendo, she's an obesity specialist and has obesity. And she posted I am going to work on, that's something I'm being a part of right now, is going through and kind of helping doctors do better in this area. Right. And she was like, what would you, as a community, what do you want them to know? And I stitched in and I said, I think that they should ask for consent to talk about our weight. And people were floored. And I even had people that are practitioners that were like, I should never, why? Why? Take the first couple of seconds to just approach the subject in a kind and empathetic way. Let the person choose and be safe. It's not like they're going to go, no. And they may. And if they do, respect it, build the relationship. But people were like, they should never, if we're at the doctor, they should be able to talk about whatever they want. No, it's not that. It's right. It's building the relationship,
No, you're absolutely right.
I got some heat.
No, I mean, I think you're absolutely correct. I think it should be asked if it's okay, or if somebody wishes to discuss something, right? Just like any other part, right? Of your medical history. It's not like you, as a doctor, I would, broach the topic from and take someone's sexual history. Hey, is it okay if we ask about this because I'm looking for X, Y, and Z things? I can also broach that topic with a patient and say, hey, I noticed you have some other medical conditions. I think potentially they could benefit from some weight management. Would you like to discuss that today?
Yeah.
And it can be as simple as that, or it can be an open-ended question before the patient leaves the office and just say, is there anything else you want to talk about today? And I can't tell you how many times patients will say, there is something I want to talk about, but I've had a very bad experience in the medical field about it. I'll say, what is it? My weight.
Yeah.
Right. Or sometimes it's also about, like you said, having that dialogue. I have patients now, charts. A lot of times patients are reading our charts, right? And what notes we're writing, and they're your notes, so you can access them.
Yeah.
And, oftentimes people will see that a doctor has written, obesity, BMI 30 to 39, let's say. Yeah. And they'll question it and they'll say, why did you write that? right? But sometimes it's not only us charting it, sometimes there's a reason. The main reason I tell doctors that, it's important to record that is to really push it as a medical disease, as a diagnosis, so that also insurance at the end of the day maybe can recognize this more prominently. And, that'll help better advocate for hopefully, medications, the correct treatments, more options in terms of lifestyle change coverage, whether that's a gym membership or,
Right.
a fitness app or something for medical health coverage when it comes to obesity.
Yeah,
Right. So,
absolutely. We have a lot of people, I would say, in our community. It was interesting. I saw recently, I think the statistics were like, there are this many people that are on GLPs, and we expect there will be like 9% of people will be on GLPs in like the next 5 years. And here's what I was thinking. That's it? Like 40+% of America plus 70, like if we're talking about, oh, whatever, that's it? And just that amount is making like Nestle come up with a new line of like what we should eat and stuff. Like, I mean, that I'm glad they're working on it now. I would say they contributed to the obesity quite a bit, but regardless, like I'm fine. I actually don't have a problem with it. I just want people to do better. Like that's where I'm at this point. Just do better. But like I think that it blows my mind that these are available and that so few people know about them. Of course, that they're very expensive. So we are global. I got the nicest note the other day from somebody in Germany that was like, I just want you to know, like, you guys are an award-winning podcast, but you are definitely award-winning here in Germany, and we love you. And I was, so there's people everywhere, right? That deal with this disease, like in all different countries, all different price points in terms of these medications, right? But I think that it's also important for us to talk about these may be, well, Kat and I don't say like it's a silver bullet, right? Like there are things that we think that we've learned on our journey that I don't like to say like it's that you have to do, but if you want a rich, full, healthy life, which is what you deserve, there are some things that need to go along with just taking the medicine. Or there are some people that may not be able to leverage it. And there are other medications, right, that maybe are not endocrine therapy that could possibly help treat obesity, right? Or treat symptoms, I guess, better thing to say, of obesity and try to help maybe even control the weight before it gets to a certain place. We don't want, if we're only talking about 10% of America that are going to be privileged enough to have this, like, what about the rest? So we would love to like open that discussion with you if you're willing to have it. I think that people would love the knowledge.
Food has definitely been a very dominant voice in my head. That's not the main focus anymore. Dieting, exercising, and adding GLP-1s through Row is a game changer. I have such a sense of mental freedom since I started with Row. Food no longer controls my thoughts. Family time used to revolve around food, and now it revolves around what we're gonna go do together.
Yeah, absolutely. I mean, I think one thing that you said is very true is that in 6 years, right, 1 in 2 people in America are going to qualify as obese, right? So we clearly have a problem at hand that we need to create tactful and comprehensive solutions for everyone who's grappling with this disease process. One thing you mentioned earlier, it's a multifaceted disease, right? So people can have underlying eating disorders or disordered eating. People can have a family history of obesity. People can have comorbid conditions, right, that actually maybe even propel their obesity. They can be on medications that cause them to gain weight. There are so many reasons somebody could develop obesity. And really, it's 3 different levels of treatment that we really look at, when it comes to lifestyle changes, medication therapy, and surgical therapy. And I think it should be an open discussion with your doctor about all 3 of these from the get-go, and then you decide which one you qualify for or not, and which one you would actually like to pursue. Yeah. And I always feel like combination therapies are quite important because obesity is such a complex disease, right? So you want to make sure that it's not a single strategy, that you actually have a good team of really specialized individuals. So that can be your doctor, that can be your nutritionist, that can be your mental health provider, that can be your fitness specialist. You really need to have a good team on board. And that also means your subspecialist, right? So you might have your primary care doctor, you might have an endocrinologist and an obesity medicine specialist. You might have a doctor for your fatty liver disease, or now called MASH, right? And there are so many different comorbidities that go with that. You have your gynecologist, maybe for patients with PCOS, and there are so many different people that you might need on your care team. I think the most important thing is, as a personal goal for me, and another reason why I came into this field is because I don't want people to progress to a point where we have to be reactive. I would prefer to approach a disease process like this from a proactive standpoint. Granted, I do the reactive, decision making every day with my patients, but I think it's really important if we took a step back and kind of approach this from a proactive standpoint, because we really want to try to prevent this disease process and the sequelae of it, right? And the sequelae means that you either have a medical condition, like let's say you have insulin resistance, right? Or PCOS, and that's linked with obesity. They can propel each other. So you want to try to mitigate them as much as possible from the beginning.
Yeah, absolutely. So I know, like, when we first started this, we were like, I remember asking one of the doctors, like, what came first, the chicken or the egg when it came to insulin resistance, PCOS,
Yeah.
like, we don't know. Right.
Yep.
It sounds like the answer is which is like a struggle,
Do they oftentimes exist together?
Absolutely.
Insulin resistance. Okay.
Yeah, so 50 to 90%, of people with PCOS have insulin resistance. 50 to 70% of individuals with PCOS are living with obesity. So everything's very closely linked. And we also quite don't know the exact mechanism and relationship between insulin resistance and hyperandrogenism, or that elevated, male hormone that we see. But that's why I said that pathophysiology, those mechanisms, we don't quite understand fully. We do know that there's an inflammatory component. We do know that, insulin resistance is also very complex in itself. It's also a precursor. You can think about it as a precursor to prediabetes and diabetes. It's really a subnormal response to normal insulin concentrations, which is really complicated to understand, right? So what do I mean by that? I'm basically saying that when you eat something, right, the job of your body is to, once it's, taking complex carbohydrates, breaking down to simple carbohydrates, and that sugar, your pancreas releases insulin, which is a hormone. And that job of insulin is to kind of take the sugar up into tissue and either use it or store it. So insulin's almost like a key to the tissue that takes up the sugar. But if your body's having a subnormal response to insulin, that means the insulin that's producing is not doing a good job of removing the sugar from the bloodstream. And what does that mean? It's going to try to do a better job by pumping out more insulin. So now you have hyperinsulinemia, which is more insulin. But there's going to be a point where your body is not going to be able to get that sugar out of the bloodstream. It's going to keep pumping out insulin. What does that mean? That means the sugar level in your blood is going to start getting elevated.
Yeah.
And that's, at some point, that will hit prediabetes. And at a further degree, that will hit diabetes. So these are things that we want to watch out for and help reverse, right? So weight loss can help sensitize your body to insulin. There are certain medications that can help sensitize your body to insulin. So we know the GLP-1 receptor agonists are good at sensitizing your body to insulin. So, that's underlying mechanism is very important for knowing if a medication is going to be helpful for somebody.
Oh, okay. Great segue. Because I was going to ask, like, how are GLP-1s helping to treat PCOS? Also, you may know this. Do you know if there's any clinical trials coming up that are actually studying GLP-1s and PCOS and the alleviation of those symptoms?
Yeah, because we get metformin so much, like and we're like, but that we don't, from what I understand, there's not even indication approval to treat PCOS for that, but a lot of people will take it.
Well, we have an armory of medications that we use for PCOS, right? So metformin is one of them, right? Birth control is the other one. Spironolactone is another one, right? So metformin can help in the sense that it does have some insulin sensitization, right? It can also help with ovulation, and very slightly, it can also help lower some of the male hormone levels. So a little bit more nuanced than what we actually may hear about with metformin. So it's not actually, a bad option. I think the thing with metformin is we need to counsel patients on appropriate use and about the side effects, right? And I think that's with any medication. If you go online on Google and you Google a medication, you might find horror stories, right? But it's really important.
GLP-1s, you probably ain't gonna go talk to your doctor.
Any medication, right? But you do the right thing. You have to talk to your doctor about it. You have to raise their concerns, and you have to listen for some tips and tricks that they might have, right, when it comes to avoiding some of the side effects with these medications. So that's a really important thing. Now, with PCOS, a lot of us are hopeful, I think, because there's such a strong prevalence of insulin resistance in the population that has PCOS. With GLP-1s, it really targets insulin resistance because it's a sensitizer. So along with sensitizing your body to insulin, it's also, delaying the gastric emptying, which makes you feel full, kind of helps your brain, regulate the hunger cues. So we're hopeful that this will have promising results in this population, but we're waiting on these official studies, right? And these big studies are really important because this is what gives people indications for using these medications for other reasons, right? So we saw, for example, with wegovy, right, that it had benefits in heart failure. It had cardiovascular benefits when it came to fatal, cardiovascular events or heart attacks and stroke, right? So we look for these bigger studies to get further indications, but we're still waiting. And I think, as much as a community we've spoken about it, we're waiting for some promising studies and results.
Yeah. With the medications that you mentioned that you were saying they used to kind of treat PCOS, most people in our community are like, I've had some people be like, no, like I was able to get pregnant because I took metformin. Like I was actually able to. And then I've heard other people be like, no, like I just crapped constantly. Like, and then I've heard other people say, actually the combination of GLP and metformin's actually been really great for me. Right. And it's sort of like, we say all the time, like the reason we can't use the prescription of eat less and move more for everybody is because everybody's body is different. Right. But the people don't think about things like that. Right. People think they are very accepting of the person that is thin and can eat whatever they want and never gain weight. And they're almost like revered, and looked at as if they are more moral than those who have the opposite issue, So we're trying to like bring some knowledge around that. But I'm curious because I think what you're saying is that these treatments are off-label treatments, right? I don't have like an indication to treat PCOS, right? So just like if we were to do off-label, if we were to use like Ozempic to treat something that is not diabetes, that would be off-label, right?
So the way to think about the indication when it comes to PCOS is we want an indication specifically for PCOS. Right now, we don't have it, but what we do have is a BMI greater than 27 or a weight-related comorbidity.
Okay.
PCOS falls under that, right? Okay. So BMI 27 plus a weight-related comorbidity, which could be PCOS, qualifies for the medication, or a BMI greater than 30. Now, granted, we also touched upon this a little bit before because Kim, you brought up so many good points that I couldn't, answer all of them in one sentence. Now I'm remembering, I'm like, oh my God, Kim did mention this. But, you were mentioning how, maybe your height, your body structure, things like that, BMI is not end all be all. It's not perfect. We use it as a population tool. Because we are missing a lot of individuals living with overweight and obesity. Now, it's not perfect. It might not capture everybody, but we're not doing enough right now. So it's not a bad tool to have because it's simple to calculate in a doctor's visit, in a doctor's office. Now, there are other things you can do. You can take waist and hip circumference. You can go get a body composition because we know that visceral fat or abdominal fat is a cardiac risk factor, right? Yes. So that's one thing. We also know that BMI is not perfect. It's not good at telling the difference between distribution of weight and risk with certain things, like how we mentioned abdominal fat or visceral fat, or even your body composition difference, right? Is this weight coming from more muscle or is it coming from more adipose tissue, right? So it's not good at telling that, right? So you can have athletes maybe that are very muscular, but their BMI might be high. And that's not to say that they have excessive adipose tissue. You would never know that just looking at BMI, right? Or there was a new colloquial term that was going around, through media and everywhere, skinny fat, right? So, individuals may be thin, but they may have a higher fat percentage in their body. So it's something that should not be just judged by appearance, right? You cannot really tell. And I also think the point that you alluded to with, you can't also say just eat less and do more, right? I have patients who are living with overweight and obesity that exercise religiously. Eat very nutrient dense diets. But like we said, there are other factors that could be into it, right? What if this patient was on steroids for asthma therapy, right? Or something for a long course or for short courses in the long term. Maybe they're on, maybe they have a family history. Maybe they have PCOS, which is, predisposing them to insulin resistance. There's so many different things that could be contributing.
Yeah. Absolutely. I mean, Kat, I don't know if you want to mention it, but like, Kat is like my fitty friend. She calls it. What do you say? I'm fat fitty. What do you say?
It's like I'm plus fit. Yeah, the
Plus fit.
fat fitty or fluffy fitness. Like,
Fluffy fitness.
yeah, yeah.
Um,
I've always been fluffy. You know, like even
she's
when I was
the
like much
exercise is
heavier, when I was over 300 pounds, I was still
You were,
working out, you know,
yeah.
consistently. It was the diet that always screwed me up, being like with binge eating disorder. And then also I've learned now that it definitely was the hormones. Like about every third day, I could not take it. I could not white knuckle. And by the third day, I was like, where is the beeping food? I'm
Yeah.
so hungry. Yeah.
Yeah. Yeah.
So this has definitely just done this.
Yeah.
Just taking
The
it in.
GLP-1s has kept you like
Yeah.
that. Yeah.
Mhm.
But even then, I mean, I will say too, like something we get questions about all the time is people will say like, you know, I'm stalling. I quit losing. I'm not losing any weight this week. I've gone up this week and all these different things. And because we're all just so conditioned to diet culture and this BMI and this number and this scale, you know, and we do lives and like we do lives because people have these questions and they're afraid to ask
Mhm.
their doctor or because their doctor doesn't know or because their doctor blames them. I mean, that's what it comes down to. And we don't give medical advice. We tell people to go to the podcast or talk to their doctor. But when people say like, why am I not losing? We have to remind themselves, or they'll go, I'm hungry. I'm hungry again. And we're like, hunger's not a bad thing, but they think it's a bad thing, right? They don't understand.
I still think of it. Yeah, I still think of it as a bad thing. Like
Of
it's
course
still.
yes. It freaks me out. Are you kidding me? Like as soon as like, but I started to learn, right? This is the journey, right? I started to learn, okay, I know the 3 days when my medicine's starting to wear off more, right? The half-life, I know I'm going to be more hungry, right? And so what I started doing is like, that's okay. That's okay. And I plan a nice meal and I have a steak and a baked potato, you know, and that's like, it's a new way to look at food as not the enemy, is not the thing that's going to hurt me. It's a thing that's going to nourish my body so I can continue to lose if I need to, just so I can continue to move my body through this earth and enjoy it, you know, and enjoy my life that I'm here for, you know? And I think that a lot of people forget that. And so we hear people a lot of times with PCOS, they'll say things to us like, actually, I haven't changed a thing. I eat the exact same way I ate before. I exercise the same way I did before. And it's just now I'm losing weight. And it sounds like you're saying, well, that's because it's treating the insulin resistance, right?
Yeah. So, you know, this medication acts on GLP-1 receptors, right?
Yeah.
So it mimics the GLP-1 hormone, right?
Yeah.
So that's a hormone that's acting in your body. And it also is going to help regulate those insulin levels. So that's very much possible. I also think the other important thing which you mentioned is really focusing on the fact that the goal of these medications is not to not eat, right? It's to actually help you maybe it may help some individuals actually do better with focusing on more nutrient dense foods, because I think when we counsel people on these medications, we try to tell them, hey, get your protein in. If that's your protein pudding, you know, creme de
Yeah,
nuit,
whatever it is, get it. Mhm.
whatever it is, you know, but you need to focus on protein, you need to focus on fiber. You need to focus on your water intake. You need to focus on exercise, right? So a lot of times in the studies with GLP-1 receptor agonists, you're going to see in the fine print listed there, these patients were on a 500 kilocalorie deficit per day and also exercising 150 minutes per week.
Yeah.
And somewhere we forget that. And so I usually have to guide patients, say, hey, this study, you remember we talked about how much weight, you know, this study showed, but it also said you have to be doing X, Y, and Z, right?
Mhm.
So it's about the complete package. You want to make sure that you're eating well, really a well-balanced diet, colorful, lean meats, lots of vegetables, fruits, good fiber sources, right? That's why I said having a power pack team behind you when you're on this journey is really important, right? Having a nutritionist, getting that 150 minutes of exercise in at least, right? You know, making sure there's weight and resistance training there. That's a part of that, right? A lot of us are intimidated. You know, a lot of my patients are like, I've never lifted a weight in my life.
Yeah.
I don't know where to start. I'm like, that's okay. You can lift 2-pound dumbbell. You can lift water bottle. It doesn't matter. Right? You can start with that.
Can get pretty good too.
Yeah. So you just start with whatever you feel comfortable with, right?
Yeah.
And it can just be bicep curls and just
going up and down the stairs. Like, I mean, you know, and I tell people a lot on this journey because it was 2 years ago. So I know that doesn't seem like that long ago, but in terms of GLP and knowledge about it, it's vast, right?
Mm.
And 2 years ago, my nurse practitioner that put me on the medicine didn't tell me anything. And I remember being like, I think this is different, right? And feeling it like pretty quickly, like a difference. And I remember being like, not doing what I would normally do on any other diet, which keep in mind, like I've had obesity and binge eating disorder since I was 8 years old. So I've always had this problem. And every year I go on more diets, and every year I go get my little outfit because I'm going to go to the gym and I'm going to do it this time, and I'm not going to eat this and I'm not going to eat that, and all of this other stuff that I feel like we tell ourselves, and we just diet culture the shit out of everything. But for me, this time, I just said, to start, I'm just going to eat a little less. And then that's all I did. I didn't change anything, just eat a little less. And then eventually I was like, okay, what if I also consider what I'm eating? And I'll tell you the reason I could do that is because the food noise was gone. I couldn't do that before. There was no considering. It was just constant all the time. You need to eat all the things with all the carbs, all the sugar, and all the land. And it was so loud I didn't even know. And when it did turn off, it would turn off like a switch. And it blew my mind. Like,
that's just the dysregulated hormones, right? Like it's just,
yeah, it was, but I think that a lot of people, when they're starting on this journey, they want to go right to that way, that diet culture way. And that's not necessarily what works. I think it can be very overwhelming. Well, at least that's what we see with people in our community, if you start that way, right? But if it's just, and then I remember I was like, all right, I'll consider what I eat. And then after that, I was like, what if I move a little bit? And I'm like, well, how much can I move? Because I weighed 350 pounds, right? So I was like, how much can I move? And I was like, okay, I'll just keep up with my laundry and I'll keep up with my dishes. Like, I just won't let them pile up. And that's going to be my movement to start. Because I think you have to kind of think about like where you are, you know? But I think a lot of times people don't know that this is that because they think I'm fat because they eat too much. Like that's what people have been telling them forever. And unwinding that from your head is like crazy. Like it's like, and it's so hard to do. But when those things are regulated, like you're mentioning, it's amazing what the brain is capable of. Does that make sense? Like I just couldn't do those acrobatics before. Like I remember the first time that I had the food noise turn off, and I remember I was going, like I was going to treat myself. I was going to get my hair done, and I was like, oh, I'm so excited. Like I want a boba tea. And then I was like, no, I don't. And then I was like, I want a hot dog. And I was like, no, I really don't want that. And then I was like, what just happened? And it was like, I recognized in the moment that I was actually connecting my wants to like the feeling of the memory of eating it, not because I actually wanted it. Yeah. And I was like, what just happened? Like it was crazy because I literally could not do that before. And no matter what anybody told me, no matter, hey, you know what? Maybe just go eat some protein before you go and eat the hot dog or the boba tea or whatever. And then it'll feel better, right? Like no matter what they said or what they did, that didn't work for me, but now it does. Yeah. It's crazy. You know, you're like, I see this every day. I got nothing.
Right. Every day. I live vicariously through my patients. They come in, they tell me all this information. And, you know, again, very crucial things you're mentioning, Kim, right? Small, gradual changes consistently lead to long-term stable changes, right?
20 seconds a week to lose 20% of your weight in a year with diet and exercise. That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on The Plus Sides, Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus Sides Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together, because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault.
Hey Plus Siders, we're so glad that you were able to tune in for part 1 of the episode. Part 2 will be posted next week. We look forward to seeing you then. Have a great week, and remember, you're not alone. It's not your fault.